Welcome everyone to this MENASO webinar, and I personally thank Dr. Suhail Al-Rukn and Dr. Adil Hazani for the invitation to co-chair this session with my colleague Dr. Aisha Al-Bakr from Imam Abdurrahman bin Faisal University Hospital, King Fahd Hospital of the University. We will have a few introductions on time, but it's an honor to present the speakers, Dr. Rima Al-Marshad and Dr. Valeria Caso and Ayman. This is the program here you can see, and Dr. Ahmed Abid and Dr. Craig Anderson. I think the program, as you can see, follows the series. We start with our residents, and then we'll start with our esteemed speakers. So if you don't mind, Aisha, I will introduce Dr. Rima Al-Marshad. She's our chief resident in neurosurgery in King Fahd Hospital of the University in Al Khobar, Saudi Arabia. We're fortunate to have her as our chief resident, to be honest. She's hardworking and innovative, and has good leadership skills in her practice, and we trust her with our patients. And she's one of the few residents in the country and probably in the world that at an early stage was able to pass microcatheters inside the head. So she participates in all emergencies during thrombectomies and coilings, and we wish her a bright future. And she's going to lead off this session with talking about a case of intracerebral hemorrhage with connotations related to our talks. So, Reem, you can start.
Thank you, Dr. Hassan, for the lovely introduction. It's all because of your guidance and mentorship. Thank you for including me on the organizing committee. I will start my presentation now. Share screen. You can see my screen right now.
Yes.
I'm going to present a case study about an intracerebral hemorrhage patient and all the events that occurred afterwards and during his diagnosis. So just to state, I have, for disclosures, no financial support and no conflict of interest for this case presentation. So when we talk about ICH and when we talk about surgical intervention, we must mention the elephant in the room, and that is expansion, and also when the patient is on dual antiplatelet, and will we go for surgery, will we go for intervention? And I think that creates a lot of debate during our clinical practice. So starting off, we have a 67-year-old male. He has comorbidities including hypertension and dyslipidemia. He has a past history with diagnosed with an ischemic stroke 3 months prior to his presentation, and he was started on dual antiplatelets, both aspirin and Plavix. His first presentation or first encounter presented with right-sided weakness, slurred speech, and also had facial weakness for 2 hours prior to his presentation. The patient was sleepy, but he was easily arousable during the examination, and he had multiple attempts to vocalize. He also had right hemi neglect. This image, upon his initial presentation, you can see the large intracerebral hemorrhage, cortical, subcortical, with a mass effect upon the cortex and surrounding structure, and also we can see that the mass effect and the edema extends all the way up to the frontal lobe and reaching also the higher cuts in the CT. So this is after we repeated the scan 5 hours later. We can see that there is still expansion, and also there's expansion of the mass effect and the edema. So that's when we had to make our decision and our follow-ups. Since the patient is on dual antiplatelets and high risk, so we attempted just to go with maximum medical management, and the scan also 7 hours later, still there is expansion, still there is huge mass effect as well. This is when we thought, should we go for catheter evacuation? Should we go for a transfrontal access, in which we call it not minimally invasive, just to evacuate this hematoma and not to do a huge craniectomy or anything. But we did not operate. Why? The patient is on Plavix, and also the patient is 67-year-old. And we can see from the images earlier, he had some cerebral atrophy, which brought him some space. So the medical therapy was attempted to work. So we stopped the dual antiplatelet, we start the patient in hyperosmolar therapy, and also we have insisted that the patient not to be intubated so we can properly assess him clinically. In regards to prophylactic VTE, we started subcutaneous heparin, prophylactic dose 72 hours after the admission, and after we confirmed that his scans were stable later. So the patient was shifted to the floor, and after he was shifted to the floor, a few days later, he was stable neurologically, but then he developed another symptom, which is shortness of breath, and was associated with hypoxia. So pulmonary CTA was done, and then the patient has a huge pulmonary embolism. So that's another debate, a huge debate that happened. So we had multiple options. Either we do nothing, or we heparinize the patient with formal dose of IV heparin, and but by that we're risking hematoma expansion and a huge risk to the patient. And we thought of clot defragmentation by cardiology, but even that would still need heparin as well. So we did a scan before starting the heparinization. And then this is the scan after we start the protocol of IV heparinization 6 hours later. And we can see that there is expansion and progression of the hematoma alongside with the progression of the mass effect and the midline shift. So we resumed following the patient with the scan, and you can see that there is a huge expansion of the edema, and also the development of stroke. We'll see in this other scan, in which the patient have developed ischemic stroke. Huge anterior circulation. Also, there is some involvement of posterior circulation. So that's when we think, this is the patient now a candidate for decompressive craniectomy or not. Now, need to mention that this scan has happened 2 days later after diagnosing the patient with pulmonary embolism. So considering all the comorbidities of the patient, and also that he was on Plavix and was on heparin, and all the issues that he was not a candidate for decompressive craniectomy, and his age was 67 as well. So after that, we reached the end of the line. So we temporized all the measures until we have spoke to the family, and we assembled the family by 9 a.m. At that day, patient had fixed pupils bilaterally. There was very difficult family meeting to discuss all the issues and all the measures that we took for the patient, and about our inability to do any other measures. And the patient had passed away 72 hours later. So that concludes my presentation. And if you have any questions or any comments.
Yeah, thank you, Odin, for for the presentation. And I think it's a reality that we face every now and then. It's not all the cases are this complicated, but we have we encountered this, and I'm sure others do too. And that's why we presented this case as such, because that will be the introduction to the subsequent talks by our guest speakers. Aisha, I will give you the podium now to introduce Dr. Ahmed. Uh,
صوت واضح.
we can't hear you, Aisha. No.
We still can't hear.
I can't hear, and
I can't hear the room.
well, Aisha, I think it's hello, Aisha. Can you just say something? Can you hear us? Just nod if you can hear us. Okay. No, the sound is very far, but I can introduce Ahmed for now if you want. Uh, okay. If you don't mind, I can introduce him till we figure out the technical issue. Okay. So Ahmed Abed is one of the senior neurology residents in King Fahd Hospital of the university. So you can tell that him and Reem will butt heads all the time in the emergency room, especially when they have an intercerebral hemorrhage case. I had the pleasure of working with Ahmed in numerous code strokes, and he exemplifies what a neurology residence does in these cases, in these situations, by leading and not wasting any time and achieving record times for door to needle in a lot of instances, despite the difficulty with logistics and patients' issues. He's interested in neurocritical care. This is one of my passions, so I wish him all the best in that. And Ahmed, the floor is yours.
Thank you, Dr. Hassan, for your kind introduction and your kind words. So today I'll be talking about a case-based study about initiation of anticoagulation in post-intracranial bleeding. So I have no disclosures or conflict of interest. So our case is a 54-year-old Saudi male patient, right-handed, with a history of occipital headache since 2 days. The headache have started upon waking up from sleep, was tension in nature, involving the occipital part, was 6 out of 10 in severity, lasted for around 2 to 3 hours, aggravated by leaning forward with no relieving factors. He had no previous similar attacks before. He had no history of nausea, vomiting, visual changes, or any other focal neurological deficits, and his systemic review was unremarkable. His past medical history was significant for a history of cardioembolic ischemic stroke 5 years ago, non-valvular AFib diagnosed 5 years ago at the onset of the cardioembolic ischemic stroke. He had ischemic heart disease with post-CABG 10 years ago, a heart failure with moderate reduced ejection fraction of 33%, type 2 diabetes, hypertension, dyslipidemia, obesity, and obstructive sleep apnea. He had a previous history of provoked DVT, and he is a heavy smoker and alcohol abuser. His medication history, he was receiving apixaban, atorvastatin, valsartan, carbidopa, metformin, which was he was not compliant to these medications. Upon physical examination, the patient was conscious, alert, and oriented to time, place, and person. His vitals were remarkable for high blood pressure of 190 over 110. And his cranial nerve examination was remarkable for left upper motor neuron facial weakness, which is a residual from his past stroke. And his motor examination showed left-sided weakness, again, residual from his previous stroke. His coordination and sensory examination was normal. So he had no new focal neurological deficit. His lab workup showed a random blood sugar of 245, and his coagulation profile and basic metabolic panel were normal. As you can see here, head CT was done for the patient, which showed focal hyperdensity in the right thalamus with minimal surrounding edema, consistent with intracranial hemorrhage secondary to hypertension. So his risk assessment, his ICH score was 0, CHA2DS2-VASc score was 6, and HAS-BLIT score was 5. During his hospital course, the patient was admitted for blood pressure control. Anticoagulation was stopped due to the ICH. During his admission, his blood pressure was uncontrolled despite coverage with 4 antihypertensive medications, and his systolic blood pressure was always ranging from 150 to 200. On day 4 of admission, the patient developed a new onset left hemineglect, which made us proceed with an urgent head CT. Head CT was done. If you can see here, there is right focal hypodensity involving the parietal lobe, involving the cortex and subcortex, which was going with acute ischemic infarction. So this raises the question. So when is it safe to restart anticoagulation, and are there any alternatives for anticoagulation in such patients? So atrial fibrillation is a major cause of cardioembolic strokes, and it accounts for around 20% of ischemic strokes. The pathophysiology behind it is the left atrial appendage stasis, which form thrombus, and secondary to the arrhythmias that can go anywhere in the body, including the brain. Anticoagulation is considered to be the first-line therapy, depending on the patient's CHA2DS2-VASc score, of course. So it's a challenging case, to be honest. So we looked at the guidelines at the time. And according to the European guidelines, a case-by-case consideration approach is needed before introducing the anticoagulation. And it may be restarted after 4 to 8 weeks. Sadly, the patient developed a ischemic stroke after 4 days of the intracranial hemorrhage. Left atrial appendage occlusion can be considered in high-risk patients with atrial fibrillation and intracranial hemorrhage. And according to the 2023 National Clinical Guideline for Stroke for UK and Ireland, antiplatelet treatment should not be used as an alternative when there is absolute contraindication for anticoagulation. And a left atrial appendage occlusion device may be considered as an alternative, provided the short-term pre-procedural use is superior to the high risk. So what are the factors that we should look at before restarting the anticoagulation for such patients? So if the patient, the high risk of bleeding would include if there is no reversible or treatable cause of the bleeding, if there is multiple microbleeds, severe intracranial bleed, older age, bleeding during interruption of anticoagulation, uncontrolled hypertension, and etc. So for our patient, he had 2 factors actually, which is uncontrolled hypertension and chronic alcohol abuse. So based on this, we decided that we will go with left atrial appendage occlusion, which is a potential alternative strategy along with for long term. But the problem is, despite that, procedural anticoagulation, usually they start oral anticoagulation for around 6 weeks and dual antiplatelet for 1 to 6 months. However, in high-risk cases, oral anticoagulation therapy can be withheld, and antiplatelet therapy is prescribed at least 1 month afterward. So our treatment plan for our patient after a multidisciplinary meeting was held with cardiology and neurology team. Given the risk factors of the patients, which is uncontrolled blood pressure and history of alcohol abuse, we decided to proceed with the left atrial appendage occlusion. So after the left atrial appendage occlusion, the patient started on dual antiplatelet for 6 months, and then single antiplatelet for life. A transesophageal echo was done, which showed no thrombus. So a take-home message from this case, based on the current data, anticoagulation can be initiated 4 to 8 weeks after intracranial hemorrhage. However, further studies are needed to determine the true risk and benefit profile of anticoagulation resumption after intracranial hemorrhage. The decision to restart or start anticoagulation after intracranial hemorrhage should be on a case-by-case basis, and a multidisciplinary approach is advised. And keep in mind that left atrial appendage occlusion is a safe alternative option for patients with atrial fibrillation and intracranial hemorrhage. Thank you.
So thank you. Can you hear me now?
Yes.
Okay. Thank you very much, Dr. Ahmed Abed, for this nice and challenging case. Well prepared, and the floor is open. So if anyone have any question or regarding this case, or we can proceed to other second speaker, Dr. Sam.
So I'm just looking at the Q&A box. There are a few questions about CME. We'll leave that to the organizers. There is one comment about the case for Dr. Reen. Was the ICH primary or hemorrhagic transformation from MCA infarction? I think the case was obvious. It was mostly epicenter.
It was primary.
Yeah, no. For Dr. Reen, the first presentation, I think the
first
case was. Yeah, but it's the same thing. So both are primary, and I think the complication in the case, or the complicated course that the patient developed, an MCA stroke on top of the ICH. So the other question was.
I think there is one question. Doesn't left atrial appendage occlusion can be complicated with cardiomyopathic stroke?
Yeah.
Dr. Ahmed, can you hear me?
I think we can leave that question maybe to the end, just to see how this will pan out. And hello, Aisha. And so if let me just check one more time if there's any questions. Okay, so we're going into trials, and I think this is the floor for our speakers to introduce this concept. It gives me a great pleasure and privilege to introduce Professor Valeria Caso. The thing I met her first time in ESO in like many years ago. And she's always welcoming and sharing her thoughts and open with her ideas, and we feel privileged to be in a meeting with her where we all learn and we all get encouraged to do better for stroke in our countries. She's a well-accomplished stroke neurologist from Italy. She's regarded heavily in multiple countries, visiting professorship in University of Belgrade, and have been research fellow in multiple universities in Kiev and Heidelberg and Zurich. She is collaborating or running multiple multi-centered studies, and her research focuses on heart-brain interaction, intracerebral hemorrhage, and acute stroke management. But foremost importance is that Dr. Valeria Casor is always makes us feel welcome and makes us feel good about ourselves, although we face a lot of challenges. And I say this with sincerity, Dr. Casor, because during COVID, we all faced a lot of problems, and I remember the Zoom meetings that we had, and the way you simplify things and you make us feel good about what we're doing, although we feel horrible. But I think that's the blessing for you, for your life and the life of those around you. The floor is all yours.
Thank you for these really moving words, because when I think back about this COVID time, and I remember was I received a lot of WhatsApp from my friend, passed away friend Hani Aref, which was, I always will remember, he was always sending me some encouraging messages. And because Italy, it was a terrible moment, and it was good to have the possibility to share these moments with all of you. And as you said, stroke, when you choose stroke, you choose very difficult patients, because in the end, they will always feel that they lost something. And you have to tell them that despite they lose some of their abilities, they have still more than 100,000 abilities as a human being to compensate. But it's very difficult because, cardiologists have an easier life because they save life. We will always have to work with disabled patients, even if we do a very good job. Even if this is only a small hand or something like this, they will feel that they lost something. So these are my coming back to my talk. This is my disclosures, but all my fees are paid for research for my young physicians to continue to do research now in this challenging time. So the point is, what should we do after? If the question is if antiplatelets cause recurrent stroke. And this is a very important question, because you asked me to speak about this because we heard about anticoagulation or anticoagulants. In this case, you choose the left appendage occlusion, which I'm not always so much in favor, because the evidence is not there. But for example, for atherosclerotic patient who had an intracerebral hemorrhage, should we start antiplatelets? And you see, this is the number of patient who restart. Who avoid antiplatelets. They had 23 recurrent ICH, and those who start had 12 recurrent ICH, which is probably due to the number, because I don't think that aspirin really protect, but still this is interesting data. So we struggle in our clinical practice, because look at this MRI. So we have this 70-year-old women, subdies atria, right hemiparesis, ischemic stroke 2 years ago, hypertension, treatment with aspirin, blood pressure lowering drugs. She recovered well. So what to do with this patient, with her? Because she has all the indication to restart antithrombotic. So it's very important to be aware and pose this question, because when I started neurology, we said, oh no, Once you had the bleeding, you can never be treated again with antiplatelets. Now we are starting to treat them, to reintroduce even anticoagulants, especially due to the fact that we have the NOACs. But still, we struggle a lot with aspirin. And what are, we need evidence, because when you talk to your patient, you have to be very confident. So you have to say, listen, this is a situation, you have this and this risk profile to develop another hemorrhage or to have another ischemia, because they deserve the way that you talk with your patient, they deserve that you talk with them with knowledge. So these are, the IST and the CAS trial, they were done, often patients were treated with aspirin before performing CT scan, which is now impossible. I don't know, there's probably, even in my clinical practice, we would never start aspirin without doing a CT, because now it's very, very easy to get a CT. But think about when these trials were done in 1997, I think it was the publication of the trials, especially in the UK, they received antiplatelets before having the CT, and you see there were patients who were treated. So, and you see there is an increase of bleeding after 2 days, after 48 hours of having the stroke. So but still the question is still a dilemma. So the dilemma persists. So we need to treat in a way a patient who had a bleeding, and especially now we know we have our, after COVID, I don't know if you have the same feelings or the same categories of patients that you see. We see a huge increase of atherosclerotic strokes, not always, not even so much carotid stenosis, symptomatic carotid stenosis, but a diffuse atherosclerotic disease, intracranial, intracranial, extracranial, which are not always symptomatic, but still these patients deserve aspirin treatment. So, and we know that aspirin clearly, especially after stroke, reduce the major adverse cardiovascular event, the MACE. But what we know is that they increase the risk of intracranial hemorrhage. So, the Men Health study was the one, for example, for primary prevention of stroke with aspirin. We clearly know that men, especially men, have a higher risk of intracranial bleeding. These data were not so much confirmed in women, because it seems there's a protective effect of antiplatelets in primary prevention, but still something that we see from the big studies, that primary prevention probably does not work with aspirin. But when you're talking about secondary prevention, clearly you have a major benefit in these patients, treating them by aspirin. But you have always a trade-off of increased risk of hemorrhagic stroke, especially when you had a hemorrhagic event. So, but on the other side, there is other things that we need to worry about after in intracranial hemorrhage. So we know that there is a risk of a recurrent ICH. There is risk of lone IF. There is risk of comorbid occlusive vascular disease without IF. And you see that compared to the recurrent ICH event, all the major cardiovascular event, the MACE, are much higher compared to the risk of having a recurrent hemorrhage. So something that we have to protect our patients. So clearly, we need to be careful. But still, we have to think that these patients need to be protected. And again, evidence. There are good trials that had been published, the Picasso trial, chilostazol versus aspirin, showing that chilostazol reduced the hemorrhagic risk compared to aspirin. Restart trial, I will show you now in a minute what are the results of restarting aspirin after intracerebral hemorrhage. Then we have Restart France, Startage and Aspirant. So these are all trials which are still in follow-up, but we have the data from Restart, and I will show you. So these are Restart trials. So we had 537 patients included. They're taking antithrombotic therapy for the prevention of vascular disease or vascular disease in intracerebral hemorrhage, who discontinued antithrombotic therapy or survived more than 24 hours. So this patient, this is the trial that will go on. Those patients will be randomized, which is very important, within 24 hours after intracerebral hemorrhage to start or to avoid antiplatelet therapy. Clearly, there will be follow-up for vascular events, deaths, modified ranking scale, adherence, and blood pressure controls. And these are the results from the main results. So the primary outcome of recurrence of intracerebral hemorrhage in those who started and compared to those who avoid antiplatelet therapy, you see there was, I think this is really a statistical artificial effect, that those who started has less hemorrhagic event, but which is in my view very important, that they had less MACEs compared to those who did not start. So this is reassuring that they had less intracerebral hemorrhage. I would say if they are on the same side, this is probably more right than to think that aspirin is protecting from intracerebral hemorrhage. However, you see these patients were protected for having more MACE and to have more vascular events. And these are the different clinical outcomes. You see lobar hemorrhage, but on these, it seemed all these events were protected more by the reintroduction of aspirin. You see also the different hemorrhagic location. Also, this way you see there was also no difference if these hemorrhage were larger, smaller, and so on. So quite reassuring to restart antiplatelets after intracerebral hemorrhage. So this led clearly to indication of the guidelines, and you see, for example, the Canadian stroke best practice in patient with an indication for continued antiplatelet treatment, reassuming antiplatelet therapy is reasonable. For the CSA, this Chinese Stroke Association, if necessary, in patient with intracerebral hemorrhage may consider antiplatelet monotherapy, which is important. Think about a patient who had a stent, okay, 2 weeks before an intracerebral hemorrhage. Probably you will not maintain a DAPT, but you can consider, and this is what we personally do, to maintain at least one antiplatelet in this situation. These are the American Heart Association guidelines. In patient, again, may be reasonable to maintain antiplatelets. Same here, after 24 hours is reasonable to restart antiplatelets, which is the same that we do. Again, pay attention to all the risk factors, because never treat only one aspect of your patient. You are a doctor. Look at the patient, look at his holistic approach. family situation, talk with your patient, please stop drinking, start moving, reduce carbohydrate, take care of yourself, reduce your stress. And then you can, this is all the aspect that you have to consider when you talk to your patients. So, and this is a very interesting, and I will finish with this. This is now the trial that Rustam Al-Shami will do in UK. Again, they will do the aspiring antiplatelet secondary prevention international randomized study after intracerebral hemorrhage. So they will include all patients who have symptomatic stroke due to spontaneous non-traumatic intracerebral hemorrhage more than 24 hours after onset, when the patient is uncertain to start or to avoid antiplatelet monotherapy. Clearly, post-traumatic will be excluded. All the ADM, hemorrhagic transformation, where you already maintain aspirin or other antithrombotic drug after ICA is already ongoing, and if this patient is not available for follow-up. And this study, again, central randomization, start monotherapy. The sample size was calculated more than 2,000 patients for the avoid and the start group, and there will be follow-up for 1 to 5 years. I think this is a very, very important academic trial, so absolutely necessary to let's say, to have more evidence and also to comfort you in the way of restarting antiplatelet after this. And this study will is now going on. It's sponsored by MENASO. It's a merely academic trial, and so now hopefully we will have new evidence. And this is a slide that I get from Rustam, and I think this is I love this so much. He used this for the World Stroke Organization conference in Toronto. Don't be defensive. Don't be afraid of bleeding. Bleeding, we know it's a stress situation for our patients. It's absolutely when they survive, but the good thing is when they survive better than ischemic stroke patient. It's a hard job to survive intracerebral hemorrhage, but the fact is that as it is a hard fact to survive an intracerebral hemorrhage, it's also that patients are undertreated. And now, thanks to Greg Anderson, who will speak after me, we have more and more possibility to treat better our patients. So, and with this, I want to conclude in order to give you more space to discuss about this topic. Thank you very much.
Thank you very much for this interesting and practical about restarting anticoagulation, or sorry, antiplatelet after ischemic stroke. It's my pleasure to present our second speaker, Prof. Craig Anderson. He is a professor of neurology and epidemiology in the Faculty of Medicine at the University of New South Wales, and is a clinical academic neurologist at Royal Prince Alfred Hospital, Sydney, Australia. He is Executive Director of the George Institute China at Peking University. He has published widely on the clinical and epidemiological aspect of stroke and the clinical trials that had a major influence on a clinical practice guideline for stroke treatment and prevention. Dr. Prof. Anderson, who will present to us acute management of ITH and role of case bundles. Welcome, Dr. Anderson. The floor for you.
Hello, everybody. I'm just trying to organize my screen. Do you see the whole screen there or just part?
Actually, yeah, the whole screen, I think.
That's all right for you? Is that a good screen for you? I'm just checking.
No.
No.
It shows the layout of your presentation. It doesn't show us the slide that you're presenting.
What about now? That better?
No.
Yeah.
Oh, yeah. Now it is.
Yeah,
Yes.
now it's better. Yeah.
Okay. All right. Well, hello, everybody. And it's my great pleasure to present at your education session on the role of care bundles and intracerebral hemorrhage. And this is very important for us because it set some very important evidence in a new direction for active management in intracerebral hemorrhage. I have some disclaimers. I have editorial roles and receive grants from government and industry. First of all, what is a care bundle? There is a definition of this that's been provided. It's several evidence-based interventions that are put together as part of a package. And the hypothesis is that when bundled together as a system of care, they're going to work better than when they're used individually. And it's to be used as part of a system of care, which is to be applied across all of our patients rather than our conventional approach, which is to choose what we think is the best patient to receive our treatment or not. And clearly behind this, there has to be evidence to support the intervention where there's little or no controversy and we all agree that this is going to work. Now, this approach was first introduced by Professor Sandy Middleton, who's a professor of nursing in Sydney, and her team, where the bundle was a component of treating fever, hypoglycemia, and doing a formal assessment of dysphagia, what she called the FEST protocol, to be used quite liberally within 72 hours of admission to a stroke unit. And to all of our surprise, in this cluster system of care trial, there was a very impressive improvement in clinical outcome on the modified Rankin scale. You can see the shift in scores in the figure, which you would not expect from any individual component of this intervention. And this has had quite a significant impact in terms of protocols and stroke units, not just in Australia and around the world. Professor Adrian Parry-Jones, who's a neurologist in Manchester in the UK, did this before and after study to look at a bundle of care for patients with intracerebral hemorrhage who came to his hospital, Salford. He called his bundle ABC, reversal of anticoagulation, primarily using PCC for warfarin anticoagulation-related intracerebral hemorrhage, early intensive blood pressure lowering to the INTERACT-2 protocol, and a care pathway with particular patients with a moderate to severe ICH who would need active care and surgical intervention. And this is the graph of the trend across the phases of the study from a pre-intervention control group to the immediate end of the intervention phase, and then following up with a post-intervention sustainability assessment. And there was this remarkable improvement in survival. Now, obviously, a before and after study is not as rigorous as a randomized controlled trial. There's various confounders. And so you need to look at whether the patient characteristics change over time. And here's the phases of the study before, during, after implementation. And reassuringly, across demographic features, there were no changes in the characteristics or severity of stroke. There were some changes in the pre-hospital transfer of care to the hospital because obviously the implementation had a flow-on effect into the community. The interesting thing about the care bundle implementation is it produced other positive results over and above those three components of the ABC protocol. You can see that the door to treatment time improved for the management of elevated blood pressure, and the number of patients going on to neurosurgery improved over time. But down the bottom, there was a reduction in early use of do not resuscitation orders. And we know from other studies that this low threshold that many clinicians use on the assumption the patients are going to have a very poor outcome, unlikely to survive, or survive with good levels of physical function, has independent significance in terms of mortality. I know that in many parts of the world, do not resuscitation orders are not used very lightly, because active care is very important for the family and the patient to be doing something. But I'm ashamed to say that in the West, we introduce our own assumptions and opinions about quality of life, that maybe the patient should be palliated quite early. And I feel very ashamed when I see that many patients come from the emergency department with a very severe intracerebral hemorrhage who may already be given morphine, which is not an appropriate use of therapy, and we need to avoid that. So active management, doing something in the protocol, did have some flow-on effects in terms of other measures to manage the patient. So this was the approach that we wanted to look at in the INTERACT-3 trial, was to bundle together early intensive blood pressure lowering with the management of hypoglycemia and pyrexia, and for the reversal of anticoagulation. Actually, when we thought about this study, it was how to give early intensive blood pressure lowering a bit of a boost. If we put other interventions together, it might have a synergy effect and enhance a beneficial treatment effect to patients. And we were fortunate to have a positive results, which I'm sure you're familiar with, which was published in The Lancet last year, and I'll show you some more details about this. So we use this design, which is called Stepped Wedge Cluster Clinical Trial. And the purpose here is to randomize hospitals rather than individual patients. We do the analysis at the individual level to measure their clinical outcome, but we randomize hospitals. It's a bit like a quality control, quality improvement package in the hospitals. And every hospital starts off in a control usual care phase. This is the orange. And then hospitals are randomly allocated to move across to an implementation strategy to implement these time and target-based protocols that we put together as part of the care bundle. So we invited over 200 hospitals around 10 countries. Most of those were in low middle income countries. In the Middle East, we included Pakistan. We also included India and Sri Lanka and Africa. And ultimately, we had 122 hospitals which were randomized. One actually had to drop out because there were some irregularities. They failed to get approvals from the regulatory agency in China. So ultimately, 121 hospitals, over 7,000 patients randomized. And because we use a cluster design as a system of care, every patient coming in with an intracerebral hemorrhage within 6 hours, we could include everybody very quickly in the intervention rather than the conventional choosing individual patients. So we're able to include people with very large hematomas and those who needed neurosurgery. In fact, 2/3 of our network that we put together in China were neurosurgery networks. So that was very good because these are the patients that have been excluded from the previous trials, and we've had uncertainty. And in fact, I never imagined that blood pressure lowering would have any effect in people who have a very large hematoma. So these are the characteristics. I would imagine these are very similar to the characteristics of patients in your country, early 60s. In the West, the average age of intracerebral hemorrhage is the mid-70s. So we know that bleeding in the brain affects younger people because of poor control of blood pressure. And also intracerebral hemorrhage is a disease of the deprived, as opposed to more affluent people where we get bigger body habitus, more diabetes, more atheroma, get more ischemic events. But intracerebral hemorrhage is thinner people with hypertension, high levels of salt, smokers. And as you can see here, most of our patients in the trial were unskilled farmers, drivers, as opposed to professional workers, and most had a history of hypertension. This is the baseline parameters. They obviously came in hypertensive, and the median NIH stroke scale about 12, so it's moderate severity. But in the number of patients here, you can see that we've got very large numbers of patients who have got very large hematomas over 30 mil. Most were deep. About a third had intraventricular hemorrhage, and we know that's an independent predictor of survival. Most had elevated blood pressure. A third had hyperglycemia, and only a small proportion were on anticoagulation. And I guess that's one of the issues that may be a criticism of INTERACT-3, is that in the Western countries, high-income countries now, intracerebral hemorrhage is occurring. The frequency of anticoagulation use now is approaching 20%, and we didn't include as many of those patients in our study. So most patients, well, 2/3 were managed in neurosurgery, which I alluded to before. That was sort of purposely part of our network. Most had interest, so the whole intervention's driven by blood pressure lowering, but also glycemic control and hyperexia. And I've talked about the reversal of anticoagulation being a minority. So we don't have as much information here that we would like. And the other thing about a cluster clinical trial is not just looking at the characteristics of the patient, but it's also what was their management, because we have to make sure that the intervention didn't alter any other aspects of their management that may be a confounder, and particularly over time, because we did this trial before and during COVID, which created a lot of challenges for us. So about a third had decompressive surgery, fifth were ventilated, a third with ICU admission, and you see down the bottom very few got early DNR use, and it was balanced between the two groups. So these are the characteristics of the physiological parameters. We had an overall 7 millimeter difference in systolic blood pressure in the first hour, and it attenuated over 24 hours. Patterns for glycemic control, very small, and very small for body temperature. And we were aware of these results during the course of the trial, and I know we were a little disappointed to see this, because we were thinking, how would this ever translate into a positive outcome, because they're very small differences between the randomized groups. But lo and behold, it did in a very impressive manner. These are the shift in the scores in the modified Rankin scale, which I'm sure you're all very familiar with. And you can see that there's a very impressive reduction in mortality between the usual care group and the care bundle group, 17% to 14%. And the overall common odds ratio, 0.86, was highly significant. We did a large number of adjusted analyses, sensitivity analyses, varying degrees of imputation of the missing data, and everything we did on the primary outcome was consistent. It's a very robust result that cannot be explained by any other abnormality in the data. And here are the individual components of the secondary endpoint. As I said before, a mortality benefit of almost 30%. You have never seen that so impressively before in any other intervention in intracerebral hemorrhage. We got improved quality of life and discharge. Less impressive on the National Institute of Health stroke scale, but maybe that was related to measurement error. I've put on the far right the interclass coefficients, which is a measure of how much the variable is consistent within a site, because obviously there's some effects of the clustering, and they were all quite low in the significant results, which is quite good, but the non-significant, like the first one of 0.23, that suggests there's some error or some effect which is related to the measurement of site, which is probably to be expected. So look, the results here is that it's a very clear message that our patients with ICH require active protocol management as a system of care, and particularly driven by the use of intensive blood pressure lowering as soon as possible. And there are various campaigns going on now and implementation strategies to try to improve our systems of care, because, as you know, patient comes to the CT scanner. As soon as there's blood noted on the scanner, the level of activity does diminish, and the patient comes back to the emergency room to wait for the next step, whereas our ischemic stroke patients receive a very busy level of care now for thrombolysis and endovascular treatment. Now, look, we worked very hard in Interact 3 to implement the care bundle. It's very challenging, as you know, changing our behaviour and systems of care in hospitals. We had to have a site champion, and as you know, leadership and influence is very important in a hospital. And if you're changing management, particularly in an implementation trial, you need very strong leadership to do that. We had to give data and feedback and performance metrics, and this is what we use a lot now in our systems of care and stroke unit, performance parameters. It's interesting, we have a lot of performance parameters for ischemic stroke. We don't have any for intracerebral hemorrhage, but I can tell you they're coming, and that's very important. We had to have meetings to give people feedback and try to influence them in their performance. And again, you do this in your own hospitals, audit and feedback and education and training. And we had to do this lots and lots. And as I said before, we even had to do this with neurosurgeons, which is not the easiest of tasks. In our study, we embedded what we call a process evaluation, which is interviews with staff at various hospitals, not just clinicians, but also nurses, to understand what worked and didn't work within the study. This is the publication from our process evaluation in China. The same study has been in the hospitals outside of China, and that publication is currently under review, but it shows much the same issues that clinicians worry. We all worry. We worry about harm. We worry that intensive blood pressure may cause hypertension and harm. We worry that hyperglycemia may cause problems. We worry about strict body control. The patients themselves, it's not easy to control physiological variables. We worry, getting the right level, overshoot of the blood pressure. Our drugs are not ideal. Boluses versus infusion transfer. Glycemic control on the ward is not easy. And in low resource areas, there's problems with medication supply, pumps, infusion, monitoring, and those sort of things. Our trial did give a bit of a kick to hospitals that the executive would purchase various equipments in Africa, but outside of the trial, there may be some challenges. So the whole strategy now of doing this is very important. And how can we do it very efficiently? Well, we have just about to launch a new study that we've called Eyecatcher, which is to help give tools and processes and information to hospitals to help them with the implementation of a care bundle, which we've expanded to not only include rapid blood pressure lowering, glycemic control, but the reversal of anticoagulation with Adanexa alpha for particular NOAC-related hemorrhages, specifically to avoid DNR orders and targeted neurosurgery. And this is a collaboration with colleagues in Sweden and many other countries that we would like to be part of this consortium to help improve the management of intracerebral hemorrhage around the world. And it is an implementation study, but it uses a very similar type of design as Interact 3, which is we call batched step wedge. So instead of having the whole study as a continuous rollout, you can do this in little batches of hospitals when they're ready to go. And you can have a control phase, you have the randomized intervention and a follow-up phase, and it would be nice if there were some hospitals in the Middle East who might want to join this study, because it's not only just implementing protocols in a relaxed manner. We recognize that implementation of these protocols is time dependent. We need to run to our intracerebral hemorrhage patients because the time of bleeding is all front loaded. Most of the hemorrhage is very early in the first few hours. And if we're going to make a difference to blood pressure lowering, anticoagulation reversal, and the other strategies, it has to be done quickly. And this is the systematic overview from many collaborators led by Rustam Al-Shahi, who you have heard in the previous presentation, with this individual patient pooled analysis of all the observational studies that just shows that bleeding in the brain happens quickly and can be very dramatic. And this is the results in Interact 3. And although we got a result, we tried to break down the time metrics, and probably it was about 6 hours before we got blood pressure under control. And that's when most of the bleeding's over. And we had to show a positive result in 7,000 patients. And if we had better control of blood pressure in the first few hours, we could probably get a result much quicker or much less patients. And that's the challenge for the future. So to summarize, currently blood pressure lowering is a level 2A, which is probably useful on its own, but in the setting of a care bundle, it should be applied to all patients, and there will be some results presented at the European Stroke Conference, which may give us more encouragement about time. And this whole purpose of time and target and protocol systems of care, it's a code ICH. Get the blood pressure under control to a target. would recommend a very aggressive approach, but if the blood pressure is very high, maybe just go a little bit more cautiously, because there is some evidence, it's post hoc analysis, that just suggests that may be a little harmful, but certainly under 200 millimeters systolic, just get the blood pressure under control. There is some evidence to suggest that nitrates very early may be harmful, probably from their venodilation action. When there's bleeding, probably don't want to enhance that with vasodilation, so avoid the nitrates. An intravenous agent's preferable, you get much better control. They're not all, hydralazine, metoprolol, they're quite cheap, but once you get on to labetalol and nicardipine and clofidipine, they're a bit more expensive. There's nothing really that's ideal. Get the blood pressure control, sustain it during the whole course of study, and this should then translate into better care for our patients. So I'm very happy to finish now and open it up for general questions. Thank you again for the invitation.
Well, thank you for both the speakers for wonderful insights on acute care in strokes and hemorrhages. And Dr. Craig, I commend something you said, that it wasn't easy to deal with neurosurgeons. God knows that's difficult. I am a neurosurgeon, and I have difficulty dealing with myself sometimes. So thank you for bringing that up. And Dr. Aisha, in fact, Aisha and myself, we work together very well, and we hope that we transcend this vision that neurosurgeons are difficult, hopefully in the next century, maybe. We'll look at the questions. I think we have few. Aisha, you want to take the first one?
Yeah, so I think there is one question to Professor Castro regarding, in real life, when we can restart anticoagulant after ICH. And the same ask about, is it mandatory to reverse anticoagulant in all cases of ICH?
So just to be sure that I understood well. So the first is about when to start anticoagulation after hemorrhagic stroke.
Exactly. And the second one, that is anticoagulant-induced hemorrhage. Is it necessary to reverse anticoagulant?
First about the reintroduction of anticoagulation, you know, there are some trials ongoing to explore if we can restart anticoagulation, yes or no, after hemorrhagic stroke. Currently, there are some, let's say, observational data that shows that you can almost safely reintroduce anticoagulation after 2 weeks from intracerebral hemorrhage onset. But there is more, there are more data about deep intracerebral hemorrhage, because it seems to be safer. Now we have also some data from the ENGAGE trial that reintroducing anticoagulation in lobar hemorrhage is probably more dangerous and lead to more hemorrhagic complication, recurrence of intracerebral hemorrhage. So if you have a very high CHA2DS2-VASc score of 5 in patient with deep intracerebral hemorrhage, and you think there is an indication to reintroduce more for the deep intracerebral hemorrhage compared to the lobar hemorrhage. However, if you are lucky, then you participate to randomized trial like ENGAGE, then you can randomize, and you will have also the data, which are then stronger than these that we have now from observational studies, and you are on the safe side because you randomize the patient. However, if you don't have this, I would go deep intracerebral hemorrhage, high CHA2DS2-VASc score. After 2 weeks, I would restart anticoagulation. Regarding the reversal, it's not always it depends. So it depends. When was the last intake of the anticoagulation? So it has to be less than 24 hours, because after this there's no need to reversal, because the good thing of this new of DOACs is they are very fast. They are after 24 hours you don't have them still in the blood, but those who come before within 24 hours, you should all reverse them. And you heard this also in the bundle of care. There is a strong indication of reverse this this intracerebral hemorrhage. Also, and probably there are also some indication that you have to use specific agents. In this case, for the bigartan, you have the antibody for the factor 10-11. Sorry, for the factor 10, you have the andexanet, which seems to have a much better effect on the hematoma expansion compared to the proton blacks, which seems not to work really. We use this for many time, but there seems to be more and more data that it does not really work on factor 10 agents.
Okay, thank you, Dr. Hassan.
Yeah, thank you. There's a question, how does QASC, I think your quality assurance protocol implementation impact patient outcome? I think you, Professor Craig Anderson, I think you put it elegantly that this is the way to go, and I applaud the fact that you did it in multiple GDP countries, so that can show that it's not dependent heavily on GDP of the country, but it's on the focused care and how that impacts. But I can change the question a little bit in the sense on where do you start? Like how, if we want to start in our hospital or in our network, what would be your advice to start implementing packaged care, if you may?
Just take the care bundle protocol and just use this as a system of care. So everybody needs to be familiar and trained that this is automatic. We have very automatic systems now for acute ischemic stroke. So the care bundle should be automatic. That's what we used in Interact 3. I know it was driven by early intensive blood pressure lowering, but it wasn't just a trial of blood pressure lowering. It had the other components, and there's quite good evidence to support anticoagulation reversal to be done quickly. I'm still a little uncertain about control of temperature, but the basic science data and observational data is very strong for neuroinflammation and fever, and it makes sense and treatment's safe. So all of these together, if we've got randomized evidence on a primary endpoint for an intervention, and Interact 3 was the first trial to show positive result, then we should be implementing it. Now, of course, there are some other components that make sense to be included. Maybe better protocols around how we refer our patients for neurosurgery. Again, neurosurgery is still quite controversial, but I think we could make some sort of sensible protocols and have better communication between ED, neurology, and neurosurgery for shared care. And then the final thing, and I think it's probably less important in the Middle East, but as I alluded to before, in Europe and North America and Australia, we have a value judgment in who we think is going to survive with good functional recovery. So early do not resuscitation orders tend to be used rather liberally, and we probably need some educational level around that. I think you've got a very good active care management in your high-level hospitals, probably less of an issue there. So I think it's just familiarising people with the protocols, being supportive, and putting in place some measures, some quality improvement measures or some performance measures that you're able to monitor, get some case examples where you can discuss them and make intracerebral hemorrhage an important disease that we should all be interested in managing. The diagnostic processes are very interesting. The secondary prevention is very important. And also get the patient stories to be shared. If you talk to ICH patients who come back to your clinic, they give you some important information about how they have been cared for, which is different to patients with ischemic stroke. And these are all important to change our attitude and have a much more active management to our patients in the similar. I believe very truly that in another few years we will be managing intracerebral hemorrhage patients exactly the same way that we manage acute ischemic stroke. And unfortunately, Hassam, it means that the neurosurgeons will have to be available to intervene in our patients very quickly, like endovascular patients, rather than waiting for the next day to do the decompressive surgery, which is our conventional approach.
Yeah, I couldn't agree more. And this is what I am advocating for the last year or so, that in the local and regional meetings, that I mean, the example we have in our hospital is like a memo that we, between myself and Dr. Aisha, issued like I think 7 years ago or 8 years ago, where we actually put in place a small protocol where hemorrhages are divided between neurology and neurosurgery in a very streamlined way. Everyone knows this patient will go to neurosurgery, so everybody will call neurosurgery early on. And I echo what you said, that the earlier the better. Don't sleep on an intracerebral hemorrhage till the morning to evacuate. Go ahead and evacuate at night, and that will change lives. And I think the added difficulty, and you alluded that in that during your talk, and I echo what you said also, is that it's a network issue. So if we receive patients from intracerebral hemorrhage patients from other hospitals in our area, they have to be up the level also to transfer the patient early, rather than stabilizing and focus on stabilization, medical management, and then transfer the patient the next day. So that becomes an added layer of difficulty in this. But I think we all share the same challenges, and we all share the same goal, that we want to do this early. And I hope that we really come to a time where hematomas are evacuated no more than 6 hours from arrival to the hospital, because that would be the real change in intracerebral hemorrhage patients.
Just can I add something on this? I totally agree, and I think really we should. We are very blessed to have somebody like Greg who pushed this bundle of care forward in intracerebral hemorrhage, because everything, you know, as neurologists, we know the brain. And we are extremely structured. And to put this structured approach also in intracerebral hemorrhage will clearly make the difference. We know from all the studies about compliance to guidelines, and every disease that we see, not only neurological disease, when you have a speedy, structured approach, you change this. You change the prognosis from sepsis, which has nothing to do with neurology, but from infection and so on. You see, the faster, the speeder, the structured you go to the disease, you will see a completely different outcome. And as you said clearly, Greg, normally we said, oh, it's an intracerebral hemorrhage, send this back to the emergency room, we have other more important things to do. That now we say, wow, we have to run. It's an intracerebral hemorrhage. We have, again, time is brain. It's nothing. We have a lot of things to do. So I think this is absolutely great that you contribute to change this mindset in the medical community.
Thanks, Valera.
Okay, I think, but not sure, are we out of the time or we are okay?
I think we have a couple of minutes, so we can close this. I mean, the questions in the Q&A box are a repetition of the same. So I think we're like, there are a few. Yeah, the last thing is doing if most of the patient needs surgery posterior fossa. I think posterior fossa is a different beast. We were talking intracerebral hemorrhages in the hemisphere. So I think we can adjourn here, and we thank Professor Valeria Caso and Professor Craig Anderson for their wonderful talks, and we look forward to collaborating with you and benefit from your vast experience in quality improvement in these challenging cases and challenging patients. And hopefully we'll share positive stories about patients coming back to our clinics well dressed and walking and talking and back to their livelihoods. Aisha, you want to close?
Yes, thank you very much. So we'd like to thank our speaker, Prof. Craig and Prof. Caso, as well as our resident, Dr. Reem and Dr. Ahmed Abid, for nice and challenging cases. Thank you very much, and wish you the best.
Thank you.
Bye-bye, everyone.
Bye.
Bye-bye.
Bye.